A very good afternoon to everyone and greetings from Narayana Health. Today we are going to discuss on our Facebook live session something about endometrial cancer. We have with us Dr. Suman Mallik, who's the head of the Department of Radiation Oncology in our institute, and Dr. Kaustav Basu, who's a senior consultant Gynae Onco in our institute. So we shall start the session. A very good afternoon to both of you. Nowadays in our clinical practice, we are seeing an upward trend in diagnosis of endometrial cancer, which used to be more common in the Western population. Now, I would like to ask our panelists today, what exactly is endometrial cancer? What are the risk factors that can aggravate this cancer? And why is there an increased trend of this form of cancer in the Indian population?
Okay, so basically endometrium is the innermost lining of our uterus. So in our country, usually we used to see more number of cervical cancer, which is basically the lower part of the uterus. But nowadays, due to lifestyle changes, more obesity in our country, and obesity we know that can produce some excess hormones as well. So because of this excess hormone obesity, in some genetic factors are there which are causing more number of endometrial cancer nowadays.
So what are the common symptoms that the patient would be worried about having if they have this cancer? What are the tests which we are commonly employing to reach to a diagnosis?
So generally the patients have a postmenopausal bleeding, that is bleeding even after the onset of menopause. So usually it comes around 2 to 3 years after menopause, and they should be definitely worried about having endometrial cancer. So they should not ignore this kind of symptoms. Immediately they should consult a doctor, a gynecologist or a gynae oncologist or a medical oncologist in any institution for further investigation. Some subset of patients who are almost nearing their menopause, like perimenopausal age group in the late 40s, early 50s, they have heavy bleeding during their menstruation. So this group of patients should also be screened for the risk of endometrial cancer. So ideally the first test what we do in this sort of patient is an ultrasound examination, preferably a transvaginal ultrasound. If we find that, as Dr. Mallik said, there is endometrial thickness, which we see, if there is increase in the endometrial thickness, we do a biopsy from that from the thickened endometrium. That can be a OPT based biopsy, which we call a people aspiration biopsy, or sometimes when we see a growth or polyp within the endometrial cavity, we generally tend to take her to the operation theatre and do a procedure called hysteroscopy endometrial biopsy. So that will ideally give us a histological evidence of the cancer. And after that, once we get a histological evidence, then we go for further better imaging like a MRI scan, a magnetic resonance imaging scan, from which we will have a better idea about the staging of the disease. So that is how we diagnose this kind of cancer.
So what are the treatment options now available, both surgically as well as non-surgical options that we have for endometrial cancer?
So as Dr. Kaustav mentioned, that once we stage a disease, if endometrial cancer is localized, which means if it is localized within the uterus or within the pelvic organs or lymph nodes, usually the primary modality of treatment is surgery. That is removal of entire uterus with part of the vaginal cuff along with the lymph nodes. So once after removal of this whole organ, we see the stage of the disease by histopathology. So we see the stage of the disease, we see the grade of the disease, how aggressive is the tumor. So if it is very early stage disease and less aggressive variety, actually the surgery is the treatment of choice. There is no further need for any adjuvant, which means the treatment after surgery, primary treatment, is required. If it is intermediate risk group or high risk group, or there is something high risk factors are there, in those cases we give adjuvant radiotherapy, and some patients they do require chemotherapy as well.
So, Dr. Basu, what are the different surgical options that we have, and what are the various routes that we can use?
Right. Like Dr. Mallik said, that depending on the stage and grade of the tumor, we decide on the extent of the surgery. Okay, so the extent of the surgery, we generally do hysterectomy. Sometimes, if there is stage 2 disease outside the uterus, sometimes we go for radical hysterectomy. Otherwise, a simple hysterectomy is sufficient. And we also see some. We also take out the lymph nodes from the regional lymph node basin, which is the pelvic node, and sometimes the paraortic nodes. We conduct a technique called sentinel lymph node dissection. So, what exactly it is? We put a dye into the cervix and check for fluorescence in the pelvic lymph node basin. This can be very well done in a laparoscopic setting or a robotic surgical setting. And we try to pick up the lymph node which is illuminates or which is glowing on the after injection of the dye. And we selectively take out that lymph node and send it for biopsy. We call it frozen section. And if the biopsy is negative, then definitely what we infer is that there is no lymph node metastasis in that basin. So we do not completely remove the other lymph nodes. So we selectively remove that lymph node, and so we are basically preventing the patient from developing the complications of total lymph node dissection. So that is one advantage. And the route of surgery, as you said, is like generally in this kind of patients, what we have is because obesity is a risk factor, the patients are usually obese. And for obese patients, generally they are diabetic as well. So we try to avoid open surgery for these patients, and even evidences have supported that laparoscopic surgery or minimal invasive surgery, be it laparoscopic or robotic, is very much applicable in case of endometrial cancer. So we either choose a laparoscopic surgery or a robotic surgery for this kind of cases.
Does this mean that compared to earlier times, we have achieved a greater development as far as the extent of surgery?
Right. So with development of skills, surgical skills, we have now reached that extent so that we can dissect these difficult areas like pelvic lymph nodes, paraortic lymph nodes. It's takes a little bit of skill in case of laparoscopy, but in robotic surgery, with the extra advantage of movement of the robotic instruments, we can very well do comfortably this kind of.
Earlier, what was considered as inoperable has now become operable. So, Dr. Mallik, what is an adjuvant therapy, and what are the factors which help you to decide whom to give adjuvant therapy and who are the candidates for adjuvant therapy?
So, adjuvant therapy is basically the treatment we offer after primary treatment, that is surgery. So, adjuvant therapy, there are two options, either individually or in combination, that is radiotherapy and chemotherapy. And that depends, as I mentioned before, depends on grade of the disease as well as stage. So stage we determine by the thickness of endometrial cancer or myometrial invasion. So we see whether that myometrium is deeply invaded or it is superficially involved, and we see whether the lymph nodes are involved or not. If lymph nodes are involved, then chemotherapy is required. If it is high grade, then sometimes chemotherapy is required. So basically, either it is radiotherapy alone or it is combination with chemotherapy. And in radiotherapy as well, there are two forms of radiotherapy. One is brachytherapy, that is internal radiotherapy. For very early diseases, that can be treated with brachytherapy alone after surgery. and it's very well tolerated. There is no side effect as such. And in those patients where lymph nodes are involved, or those who are operated from outside and inappropriately operated, so in those cases actually external beam radiotherapy is one of the option. And now we have seen as like evolution of surgical techniques, we have seen evolution of radiotherapy techniques as well. So nowadays we have image guided radiotherapy, IMRT, by which we can reduce radiotherapy related side effects significantly. So now patients can tolerate radiotherapy much better way compared to our previous days. And once we complete radiotherapy and chemotherapy, those patients are usually kept under close follow-up. Usually we follow them up 3 monthly every for up to 2 years, and then thereafter 6 monthly. That's it.
Okay, with the development of both the surgery and the radio and chemotherapy techniques, what is the prognosis of such cancers? Are they curable?
Right, so it's a very good question, because endometrial cancer are a very indolent kind of cancer. They do not rapidly spread out to the other organs. We try to, because since the very common first symptom of endometrial cancer is postmenopausal bleeding, so it is easily detectable in early stage, other than on the other counterpart ovarian cancer, which is generally detected in the stage 3. But endometrial cancer can be detected mostly in the earliest stage. But so there are 2 types of endometrial cancer, which one is a estrogen dependent cancer, other is a estrogen non-dependent cancer. The estrogen dependent cancer generally have a very good prognosis, and they try to survive for prolonged years. Generally, they do not come back with the disease, as we have seen in our follow-up missions. So it is almost, we call it 85 to 90% of survival for the early stage of cancer. But the type 2 cancer, which are non-estrogen dependent, those are mostly caused by genetic mutation, alteration. So those are having a bit of difficult prognosis. But in those cases, as I mentioned, that we generally try to over-treat the patients with radiotherapy and chemotherapy as adjuvant therapy. So even with those high-grade, high-risk factors, still I would say 5-year survival is at in the early stages is as far as almost 50 to 60%. So it's overall a favorable prognostic disease, and you can say it's almost a curable disease.
So what I understand is that this is a curable disease. However, what we must remember is that early detection always gives us an edge.
Right.
So what is the take-home message to normal population, to ordinary women? What precautions should they take, so that, and what are the warning signs that they should look out for, so as to bring their concerns to you at the earliest?
So lifestyle change is one of the important aspects that one should look for, because we all discuss that obesity is one of the cause of endometrial cancer. And the second is early detection. So whenever there is spotting, whenever there is abnormal bleeding, so they should take opinion of a gynecologist or an oncologist, and they must get treated under an oncologist, under a center where all the oncologies are available, like radiation oncologists, medical oncologists, as well as surgical oncologists.
Right. So in this era, today's era, where we have seen that genetic mutation and alteration plays a key role in development of cancer. So patients who have family history of cancer, hereditary cancers, or in their family, they should be very much aware of the symptoms. They should be made aware. In fact, they can also undergo frequent ultrasound examination, even if they don't have any symptoms, so that they can be detected very early. Especially some breast cancer patients who are kept on a tablet called tamoxifen, they have a tendency to develop endometrial cancer. So they should be kept on regular, frequent checkups. So this is how definitely we can prevent and rescue these patients.
So this brings us to the end of our session. I would like to thank both Dr. Basu and Dr. Mallik for their wonderful deliberations. Thank you very much.
Thank you.